Evening and welcome to our annual Diabetes Fair. My name is Amy O'Connell. I'm one of the diabetes educators here at Agnesian. Tonight I'd like to welcome Dr. Clarence Tam. He's one of our ophthalmologists here. His interest in ophthalmology began when he failed his military eye exam to fly jets for the U.S. Air Force. So ever since, his goal has been to make sure that people have the gift of sight and are able to live the life that they want. He received his medical degree from Baylor College of Medicine and his residency training in ophthalmology from the Cleveland Clinic Eye Institute. He is board certified by the American Board of Ophthalmology. Please join me in welcoming Dr. Clarence Tam.
Can you all hear me okay? In the back? No. I'll just talk really loud. I'm good at doing that. So today we'll be talking a little bit about diabetic eye disease. We'll start off the talk by giving some statistics regarding the disease of diabetes. We'll talk a little bit about how diabetes affects the body and what diabetes is. And then we'll go into talking about how diabetes can affect the eyes, some preventive measures that we can take to prevent diabetic eye disease, and finally some treatment options. So diabetes as a disease affects a great deal of people worldwide. In the United States, almost 10% of Americans have diabetes. And that's nearly 30 million people. So if you imagine 400 Lambeau fields filled with people, that's how many Americans have diabetes. And for those of us who are over 65 years old, about 1 in 4 of us will have diabetes. So just as a show of hands, how many here are diabetics? So look around, quite a few of us, including myself. Diabetes is at this time still the #1 cause of irreversible blindness in the world and the #7 cause of death. Diabetes not only affects our blood glucose control, but also has a profound impact on other organ systems. It can lead to heart disease, eye disease, kidney disease, loss of limbs, and also increased risks of other diseases such as strokes, high cholesterol, and high blood pressure. Diabetes is a multifactorial disease, meaning that there are multiple factors that lead to why people develop diabetes. We know that being overweight is a factor. Also, a sedentary lifestyle is a factor, but also there's a very big genetic component as well. Within the United States, when you look at the different racial groups living in the U.S., we find that there's a pretty big difference with Caucasians typically doing the best and Native Americans and Eskimos doing the worst. But even within racial groups, such as the Asian group, Chinese Americans versus Americans from East India, there's a pretty big difference. So clearly a racial or genetic component in addition to other lifestyle components. Diabetes as a disease has a staggering impact on the economy. If all of the costs of treating diabetes, diagnosing diabetes, and covering the lost dollars from days off work from being sick, if the U.S. government were to foot the bill, it would cost almost $500 billion a year. And if you look at the 2014 U.S. federal budget of $3.4 trillion, that would equate to almost $1 in $7 spent would be in treating, diagnosing, and covering the lost wages from diabetes. There are 2 types of diabetes, type 1 and type 2. In type 1 diabetes, this is an autoimmune disease which results from your own body acting up and attacking the islet cells of the pancreas, which produce insulin. So when your immune system kills off the islet cells and your body no longer produces insulin, which is necessary for the cells to absorb the sugar in the blood glucose rises. In type 2 diabetes, that is not an autoimmune disease. What happens there is that the cells will not interact properly with the insulin, so that even in the presence of insulin, the cells will not absorb the sugar. We call that insulin resistance. So two different pathways, but they both result in the same thing, which is elevated blood glucose. Elevated levels of blood glucose over time becomes toxic to the blood vessels. It damages the walls of the blood vessels of all sizes. However, the vessels that are most susceptible to the toxic effects of glucose would be the very smallest vessels, the capillaries. Now, if you look at the circulatory system of the human body, think of a tree. The aorta would be like the trunk of the tree, and then the very large branches off the aorta, like the femoral artery, the subclavian artery, the carotid arteries, those would be like the main branches. Well, the capillaries are these very tiny little sprigs at the very edges of the trees. And those little capillaries, although when you lose a few of them, has absolutely no effect on the body, but when you start seeing large amounts of dropout of capillary action, then that can lead to profound effects, because the capillaries are where the action takes place. When I take a deep breath in, I fill my lungs with oxygen, and it's the little capillaries that run next to the alveoli sacs that actually receive the oxygen through its wall and exchanges carbon dioxide also through its wall back into the lungs, so that we can constantly breathe and exchange good gases for bad gases. Same thing with nutrition. The capillaries feed our muscles with the oxygen that it needs. The nutrients that travel through the blood into our muscles and kidneys and heart, they all travel through the capillary walls. So when enough of these capillaries are damaged, that's why you end up having diseases of other organ systems that are highly capillary dependent, such as the eyes and the kidneys and the heart. In diabetic eye disease, what results from capillary damage is that ultimately the walls of the capillaries begin to fail, and you start having leakage through the walls and bleeding through the walls. Also, if the walls of the capillaries collapse, then blood flow through those little capillaries ceases completely, and you end up not being able to deliver oxygen and nutrients to the target tissues. There are two different classes of diabetic eye disease. You have non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The big difference, the big distinction between the two is that with proliferative diabetic retinopathy, you develop abnormal blood vessels in the eyes. In non-proliferative, you do not develop abnormal blood vessels in the eyes. Otherwise, both disease states can exhibit the same problems. Both can have bleeding, both can have leakage, both can have dropout and lack of blood flow to the eyes. But once again, with proliferative diabetic retinopathy, you have new vessels, neovascularization, and from the neovascular vessels, you can have bleeding in the eye. This is the picture of a healthy retina. One of my attendees in medical school always told me, you can't know abnormal unless you first know normal. And so in this picture of the healthy retina, you have the optic nerve, the central disc. From within the disc is a central opening called the cup. And through this cup emerges the retinal vessels. You have these larger, darker red ones. These are the retinal veins. And the thinner, lighter colored, brighter red ones are the retinal arteries. These vessels feed The arteries feed blood into the eye, going from the larger vessels to the smaller ones through the capillary beds, and then lines back up going into the veins and back out the eye. The central part of the retina is called the macula. You've all heard of macular degeneration. That's the part of the eye that is actually responsible for your sharpest vision. And if you look at the very center here, where it's kind of a little bit grayish, that's the fovea, and at the very, very center of that fovea, smaller than the tip of the sharpest pin you can imagine, is this little central depression called the foveola. That little central depression is where the best vision takes place. There's only one cell layer at the foveola, and those are the cells that are used exclusively for seeing. There's no other cells in that area, none of the cells that support the photoreceptors. Also, as you get close to the foveola, you'll notice, and this is not the greatest picture, but as you follow the little vessels in towards the center, you'll see a little area here where pretty much all the vessels stop going towards the center. That's the foveoavascular zone. Once you get into that area, there's almost no capillary action. The nutrients, the oxygen and nutrients that feed the retinal cells within that little center have to leak out of the capillaries and slowly diffuse or creep along the surface of the retina to feed those cells. So those cells, these cells right in the center, where you have the absolute best vision, are the cells that are the most susceptible to any damage to the capillaries. This is an OCT of a normal macula. The foveola, the very center little depression, is right here. Notice how the retina thins as it gets there, because it gets to be just basically one cell layer thick of nothing but photoreceptor cells. This is a fluorescein angiogram, also of the retina. To take this picture, we inject a little bit of dye called fluorescein into a patient's veins, and then we take pictures over time following the dye as it travels through the bloodstream. We can see that the dye is confined within the limits of the blood vessels. There is no leakage here. Everything is normal. You see the center here is a little bit darker than the rest of the picture. And even out here where there are no major vessels, you can see that there's a little bit of a flush, almost a light gray. That's because this area, even though you can't see it, there's still a very nice network of capillaries that grow all through the retina, feeding oxygen and nutrients to the retinal cells. But this little area, the foveoavascular zone, has none of that. This is what we call a watershed area, and is the most susceptible to damage. With non-proliferative diabetic retinopathy, when you first start developing the disease, the first signs that we see are typically small little areas of dilation or swelling of the capillaries. We call them microaneurysms, and they look like little red dots when we look in the back of the eye. As the damage progresses, some of these capillaries will burst, leading to patches of bleeding, and also over time there can be areas of leakage where we'll actually look into the eye and see that the retina looks thickened. Also, what we can't see, and what we sometimes diagnose, is that the capillaries can shut down, resulting in lack of blood flow to parts of the retina. And when that happens, those cells don't function well, and the vision is decreased. So the two causes of vision loss from diabetes is swelling or ischemia, which is the lack of blood flow to the retina. In this picture of early diabetic retinopathy, we have some microaneurysms. These are the little tiny red dots. There's not very many of them, and there's no swelling in this picture. With a similar picture using the fluorescein dye, we can see the dots, they light up like little Christmas tree ornaments. Once again, The dye is confined strictly to the vessels, and these are little outpouches of the capillaries. As the diabetes progresses, you see not only little microaneurysms, but also larger areas of bleeding. These little whitish yellow dots are lipids or fats that have oozed out of the damaged capillaries. And sometimes you can have fairly large areas where there's just lipids trapped in the retina. All of this is non-proliferative because there are no abnormal blood vessels. With macular edema, the vision is decreased because you're no longer focusing light onto a smooth, high-quality screen. If you have a video projector at home, you want to project it onto a smooth and as firm a wall as possible so that everything focuses on the same plane and the vision and the picture is clear across the board. With macular edema, the picture screen, the movie screen, is no longer flat. Imagine trying to focus a picture on a wall that's covered with large cotton balls. It's going to focus at different levels, and then you're not going to have a nice quality picture. Once again, with macular ischemia, if the retinal cells are not fed the nutrients and the oxygen that it needs, then the function goes down, just as if you're too tired and hungry, you can't perform. In diabetic macular edema, in this picture we can see this area. This is a ring of exudate, and there's fluid in between that we can't see with the naked eye, but with a microscope looking into the eye, we would actually see this area as being a little thickened. The fluid pushes the lipids to the side, so we have this little lipid ring. This is a fluorescein angiogram of a patient with macular edema. Now you can no longer really see that, you can see that the dye is no longer confined to the vessels. The vessels are actually largely obscured by the dye that has been leaked out, and everything just looks very ugly and chaotic. In this OCT of the macula, this whole area, what was that very thin, nice macula that has that central depression, now it looks like giant cotton balls. You have pockets of fluid. The retina, the macula, is greatly thickened, and that degrades the vision. In macular ischemia, side-by-side picture, you can't see any changes other than some bleeding. But with the fluorescein, see this big, large black area? No dye going to that area means that all the capillaries in that area were shut off. In proliferative diabetic retinopathy, the eye develops new vessels. And the reason that it does that is that the eye sends a signal saying that it needs more oxygen, it needs more nutrients. And in response, the body produces a hormone called endothelial growth factor. It's the same hormone that runs out of control in macular degeneration as well when people have bleeding. When that hormone is present, the eye will start to produce new vessels in the hopes of bringing in more oxygen and nutrients to feed the areas that are starving. Sounds like a great idea, but the problem is that the new vessels are not healthy vessels. Their walls are weak, they tend to bleed, and they're not located in the same area as the normal retinal vessels. The normal retinal vessels are located within the layers of the retina, whereas the new vessels actually grow on top of the retina. And so even though they're present, they're inefficient and ultimately can cause greater complications, especially when they start to bleed or possibly contract. When these vessels bleed, you can have hemorrhages in the vitreous, or sometimes you get pockets of blood stuck between the retina and the vitreous called sub-IOM hemorrhages, and I'll show you some pictures of both. This is a picture of proliferative diabetic retinopathy. The normal vessels are the nice orderly red lines. Here's a very large patch of the abnormal vessels, and a smaller patch down here. Notice how these are, they're just kind of a disorganized array of blood vessels. Ultimately, the vessels will bleed. This is a sub-ILM hemorrhage. The vitreous in this area is still clear because it hasn't actually ruptured into the vitreous. It's a pocket of blood between the retina and the vitreous itself. Here you can see a small little actual vitreous hemorrhage where the blood has actually entered the vitreous, and it looks kind of like pinkish smoky water. When the eye fills with vitreous hemorrhage or a sub-ILM hemorrhage, the vision can become profoundly bad. In addition to a vitreous hemorrhage, proliferative diabetic retinopathy can ultimately lead to areas of traction, which can then lead to retinal detachments. The retinal detachments can be tractional, where the fibrous bands pull on the retina and it peaks it up like a little mountaintop. Or it can actually pull enough to where it tears the retina, and then fluid can rush through the hole and detach the wall, like having the wallpaper in this room peel off. And in both cases, the retinal detachments need to be repaired. With the tractional detachments, they are repaired if it affects the macula only. But still, the underlying diabetes needs to be treated. This is a picture with traction bands. The traction bands in this picture are these white lines. You can see some proliferative disease here, and the lines are kind of reddish because there's actually some vessels that have incorporated themselves within these fibrous bands. In the picture to the left, you see these white dots where they were treated with laser. And now the vessels within the fibrous bands are gone, but the fibrous bands are still present. And they can still continue to contract and cause problems, ultimately resulting in a giant retinal tear and a giant retinal detachment. In terms of managing disease, it's always best to prevent the disease. It's a given when you have diabetes that you're going to have it pretty much for the rest of your life. But you can do a lot of things to help protect yourself from developing its complications and protecting your heart, your kidneys, your eyes, your toes. And to do that, it's both hard and simple. The first thing to do is follow instructions when it comes to taking your medications. If you're told to take metformin like I am, take it every day. If you have to take insulin, take it every day. Also, other things that can help to control the diabetes is to watch your diet, get yourself to a nice healthy weight, and also do some exercising every week, and most days of every week. The goal is to try to get the hemoglobin A1C to be 7 or less. With studies, that seems to be the magic number, where when you can get it to 7 or less, the progression of the disease slows down significantly. It helps to slow the progression so that it delays the complications of diabetes. The American Diabetic Association has guidelines for diet, weight loss, and exercise. In the past, they had some pretty stringent dietary restrictions, but now their catchword really is no one size fits all, meaning what works for one patient may not work for the other. And so we really need to find a diet that works best for you. Fad diets generally don't work because they're so stringent and so restrictive that you can do it for a few days or a few weeks, but ultimately it's very hard to do it long term, and then you regress, you eat a lot more, and you gain all that weight back. Same thing with diabetics. You really have to kind of find the right mix of foods that work for you so that you can achieve that goal of 7 or less for the hemoglobin A1C. Dietitians are a great resource for that. Agnesian doctors work with dietitians at the hospital for these purposes. Because diabetes also affects other disease processes, such as heart disease and high cholesterol and high blood pressure. They do generally also recommend watching how much fats you take in and cholesterol, and also just taking it easy with the alcohol. This is a slide from the American Diabetic Association. Notice right at the top, no one size fits all for the diet. Back when I was in medical school, the American Diabetic Association was very strict in its guidelines. If you were admitted to a hospital, it didn't matter if you were a pretty little guy like me or a big 6'5" guy who was a rancher. They would stick you on an 1,800 calorie diabetic diet. This gentleman here is laughing because it sounds like he went through that once upon a time. I actually have a little story to tell from when I was a third-year med student down in Baylor. And my team was on call, and so I admitted a gentleman who was probably about 6'3", 6'4", weighed well over 200 pounds. He was a diabetic, and because he was in the hospital, he got the 1,800 calorie American Diabetic Association diet. First day, he was pretty nice to me. The next day, he was a little bit less friendly. The third day, even a little bit less. And by the fourth day, he was downright ornery. The next day I saw him, he was once again really nice. And I was thinking, boy, he must be feeling really good, looking forward to going home. And when I would turn around to walk out of his room, I looked in the wastebasket and I figured out why. There were 2 empty bags of Hostess mini donuts. These are those bags that hold about 20 to 25 donuts. They're those little mini donuts. And each bag is probably, what, about 3,000 calories of sugar, processed starch, and fat. And I looked back at him, but I wasn't going to say anything. And he knew I knew. And he said, Doc, I got to be honest with you. You guys were starving me to death. And last night, I told my son, don't come back until you bring me something good to eat. So even though our intentions were good, the plan clearly didn't work. If you look at his 5-day stay, he didn't have an 1,800 calorie diet. He had a 3,000 calorie diet after factoring in those 2 bags of donuts. And if we had given him 3,000 calories of good, healthier food, he would have been better off. Weight recommendations from the ADA strive for a body mass index of about 25. As far as exercises, of course, always consult your doctors to see what you're able to do. But once again, the goal is not to train you and turn you into a triathlete, but to have you do some moderate aerobic activity every day, typically about 30 minutes or more, 3 to 5 times a week. When prevention fails, there's always alphabet soup. ETDRS, DRS, DRBS, DCCT. These are abbreviations for large multi-center studies that were done in the 1970s and 80s that to this day still guide how we treat diabetes. ETDRS, the Early Treatment Diabetic Retinopathy Study. This is for patients who have non-proliferative diabetic retinopathy. And in this study, it shows that when you have more than a certain amount of swelling located in a critical area, if you receive laser, over the long term, you will have better vision than if you don't receive the laser. In the DRS study, the diabetic retinopathy study, this is for patients with the proliferative form, the guys with the abnormal vessels. Once again, the study proved that if you have more than a certain amount of abnormal vessels, what they call high-risk characteristics, then you are much better off getting the laser in the long term than if you don't. The goals of the laser for the ETDRS is on top. That is to seal off the leaks and to reduce the amount of swelling in the back of the eye. In the DRS, the goal is to actually literally destroy as much of the parts of the retina that you don't really need, so that the need for oxygen goes down and the need for nutrients goes down, so that the eye will not call for the abnormal blood vessels. And the existing blood vessels will then slowly over time start to regress and shrink away. These diabetic lasers, the first two on the right, the focal and the grid, I usually do together. This is for areas of leakage with the focal laser. The goal is to try to hit the little red spots where there's potentially leakage. And in the grid, you're making a grid kind of peppering the area to just cover the areas of leakage that you cannot directly see. So by doing this, if you can seal off enough of the capillaries, then your retina's own healing abilities will soak up and reabsorb some of the fluid and eventually have you see better when the movie screen flattens back out. The one on the left is called pan-retinal photocoagulation. That's where you do literally multiple hundreds of laser spots all along the periphery. Notice the macula is spared, as is the nerve. And so when you reduce this area, not making it completely blind, but really kind of destroying parts of that retina and decreasing the metabolic need, that's the goal there. This is an actual photograph of a focal laser. You can see very faint little white spots where the focal grid was done. In pan-retinal photocoagulation, this is a montage of multiple pictures kind of put together, and you can see how each one of these little laser burns represents one spot, literally hundreds throughout the eye. In the diabetic retinopathy and vitrectomy study, they looked at the timing for removing the blood in the back of the eye. If you have the abnormal vessels and you bleed, your vision's going to be bad. But when do you have to have it done? Do you have to have it done tomorrow? Can it be done a month from now? And so that's what that study was commissioned to do. As it turns out, with the type 1 diabetes, the blood should be removed sooner rather than later. And if you wait more than 6 months, the long-term vision tends to be worse. So you try to get that taken care of relatively quickly. For the type 2, there was no advantage to early vitrectomy, so you have a little bit more of a luxury with time. This is a cartoon of a vitrectomy. A straw is put into the eye to churn up and suck out the bloody vitreous so that you ultimately take all the blood out and you end up with an eye with a nice clear vitreous and a better view to the outside world. In addition to lasers, we have now the advantage of using some medications, some injections that we also use for macular degeneration. Medicines such as Avastin and Lucentis were initially developed for anti-cancer therapies because it caused new vessels to regress. So if you have a patient with a lot of abnormal vessels, you can inject the eye, and the medicine will actually cause those vessels to regress. But it's not a long-term treatment because the need for oxygen is still there. So you treat them with an injection, you get the blood to reabsorb, and then you do the laser. You still have to do the laser. So in summary, diabetes is an epidemic that's affecting the United States and the world. Unfortunately, as much as I would like to say that the rates of diabetes is going down, in every country in the world, the rates of diabetes is going up, some much faster than others. The cost of diabetes is staggering on the world economy, and diabetes can lead to a lot of other serious health issues, including heart disease, kidney disease, eye disease, loss of limbs from damage to peripheral nerves, and a host of other problems. Diabetic eye disease is the #1 cause of irreversible blindness in the world. And treatment, although effective, is best done only when rigorous preventive actions are taken. The goal right here, A1C of less than or equal to 7. That's the number you need to remember. If you remember only one thing from this talk, get your A1C to less than or equal to 7. When all else fails and you do have to have treatment, the treatment options generally involve some type of laser therapy, and when necessary, other adjunctive therapies or even actual surgery, such as the vitrectomy. And at this time, if you have any questions, I would be happy to answer what I can. You can drink any type you want in moderation. They generally recommend no more than 2, like 2 cocktails, standard size cocktails. I'm not talking about, a 32-ounce mug of Long Island iced tea, but 2 cocktails for a man and 1 for a woman, primarily because men are generally bigger than women. It's more of a body mass thing, not so much that women can't handle their alcohol as well. I happen to know some women who can drink the end of the table. Any other questions?
What is the difference between macular degeneration and diabetic macular problem?
The diabetic macular problem stems strictly from the diabetic disease. The loss of vision is from lack of blood flow or swelling from damage to the vessels. Whereas with macular degeneration, that's actually a genetic condition that causes damage to the bottommost layer of the retina called the pigment epithelial layer. When you have breaks in that layer, and when the pigment cells start to die, the photoreceptor cells, which are your seeing cells that sit right on top of the pigment cells, start to lose its function. And so over time, macular degeneration patients will lose their vision that way. And also, when you have weakness in the epithelial pigment layer, abnormal blood vessels can also come from behind and lead to leakage and bleeding. So two different causes, but they both affect the macula. Did I answer your question?
Yes, can I ask one more?
Sure.
If you have macular degeneration, my husband has that, and for a while there, they were saying that these eye vitamins, concoctions, were appropriate treatment for that. But now there was Dr. Hussein who said not so much anymore, so.
The eye vitamins are still effective in helping to control the progression or to slow the progression of macular degeneration. But at some point, if the macular degeneration is very severe and he's already bled and he has a macular scar, then they really don't do that much anymore. But for the most part, if you have mild to moderate disease, that along with the diet that's rich in green leafy vegetables, which also happens to have a lot of those same vitamins, are very useful in slowing the progression of macular degeneration.
You have up the diet.
Yes.
And one of the biggest things that helps control that lack of salt. And nowhere do I ever read anything about, keep the salt out of your diet as much as possible, which really helps.
I didn't really read that, but I'm not an expert dietitian. But if you had read that, it's probably true. I mean, salt intake should be regulated. You shouldn't eat things that are overly salty. It does help you retain water, and it can also affect other parts of the body like blood pressure and stuff like that. Did you have a question?
Yes. Are there any new technologies that are coming along that make your job easier?
Nothing revolutionary right now. The newest technology or the newest addition to our weaponry in combating diabetic retinopathy is the use of adjunct medical injections, the Avastin and the Lucentis. Yes?
What's the best way to get your A1C below 7?
The best way is a diet that helps to regulate your glucose, eating foods that have what they call a high glycemic index, meaning it doesn't release the sugars into your bloodstream really fast where your blood glucose just skyrockets after you eat. For example, whole grains have a much higher glycemic index than processed starches. Yams are better, yams are good, vegetables, beans, things that naturally break down slower in your body. So those are very important for a good diet. Also, exercising helps to, exercising and weight loss will help the hemoglobin A1C go down. I think with exercise and with weight loss, even though if you're type 2, even if you're resistant to the insulin, just losing the weight and having a more active lifestyle does actually decrease the insulin resistance so that the cells will let your natural insulin do a little bit better of a job in helping the glucose enter the cells. That along with the medications that you take.
Why do you get so cold?
Why do you get so cold?
Why do you get so cold? Not the cold.
I would think probably not so much just from the diabetes that you get cold. There's a number of factors. Some of it can be hormonal. Some people are just naturally, their blood, instead of being in the fingertips that keep you warm, shunts more towards the center of the body. I know after I eat lunch, my fingers are really cold, because when you eat, after you eat, the body shunts the blood to the digestive system so that you can digest your food, and so some people end up with the cold fingers. So lots of different reasons why a person can be cold, but if you're constantly cold, it's good that you've talked to your doctor to make sure you don't have like an iron deficiency, that you're not anemic. Sometimes checking hormone levels can also be a benefit. Like people with low thyroid hormone can be cold all the time. Yes, sir?
Been hearing talk lately about the A1C1, for older people, where you can have a tendency to be too low.
That's correct.
Instead of too high, it might be better off to be a little higher than being too low.
Mm-hmm.
I don't know what the number would be, but it sounds a lot.
I've talked to some of my endocrinology colleagues about that, and the normal, or what they recommend for diabetics is having an A1C of 7 or less. The question is, can the A1C be too low? And the answer is yes. According to the literature for diabetics, we strive for an A1C of 7 or less. The significance of the A1C is that it takes not a snapshot in time of your blood glucose, which is what you get when you do a finger stick. It tells you exactly what your glucose is at the moment. What the A1C does is that it literally takes 1 million snapshots over the course of 3 months. And it tells you, based on the A1C, what the theoretical average blood sugar that you have is based on that number. I can't remember off the top of my head, but like, for example, if your A1C is a 6, then I think your average blood glucose is a number somewhere like around 130 or something like that. If your A1C drops much below 6, and if your average, let's say, based on the A1C number, is 100, well, then that means there's a lot of times when your glucose might be 200 after you've eaten, or even higher, but then there may also be a lot of times where it's 50 or 60, which is pretty low and potentially dangerous. So yes, you don't want the A1C to be too low, but you still want it to be low enough to where it controls the diabetes.
It sounds like, the guidelines might be set a little bit too low.
The guidelines are set based on studies where they objectively observe diabetic patients over many, many years and looking at certain numbers and hopefully finding what's considered a reasonable number. If you are not a diabetic, your A1C should be always less than 6. So at 7, which is what we shoot for in diabetics, it's already above the norm, but still, much lower than where it would be otherwise. And I also think that as patients get older, as patients get older, and if you've been a diabetic for many years, and now you're 85, 90 years old, most doctors cut older patients a little bit of slack. And I think it's deserved. But still, you do want to still watch the A1C and not let it get too high.
I'm on Victoza.
You're what?
I'm on Victoza.
Uh-huh.
In the last few months, I've seen 3 new shots that are available for type 2 diabetics.
Mm-hmm.
And one of them is for once a week.
Mm-hmm.
And, you hear these things on TV and ads, but there's no explanation that gives you the bad news about taking it.
Mm-hmm.
But you don't know
If you're a good candidate or not.
Yeah.
Yeah, that's something you should discuss with your doctor. Because based on you and based on other problems that you may have, you may or may not be a good candidate. And yes, they do always tell you what all the bad things are, because then that way they can say, you knew there were bad things that could happen to you, and now you can't call a lawyer when bad things do happen to you. Any other questions? Well, thank you very, okay.
I'm just wondering, I've had over 1,000 burns in each eye, and with all the lasering that I've had, is there anything worse that could come along? I mean, everything's pretty much lasered, and it's welded back there, so it probably wouldn't be patched.
Right.
But what could happen down the road for me?
Well, the diabetic retinopathy can still progress even if you've had a lot of the laser. So, if you've had a lot of the laser already, and if you were to once again develop abnormal blood vessels because still the blood flow isn't enough to feed the retina that you have, then the bad thing about that is now you don't have more retina to burn to decrease the metabolic need. So you kind of get to the point where you're running out of ammunition when you get to that situation. But you can still do the injections to shrink the vessel. So that's still always an option.
My wife's coming to you in December.
All right.
She doesn't wear glasses when I think she should. We got on the state a lot. She used to read the signs for me.
Uh-huh.
So I could get in the right lane.
Okay.
She can't do that anymore.
Well, maybe she has a cataract.
When you get her in your office, it's right here. Make sure you tell her she needs to wear the glasses.
You're not getting any dessert tonight. No apple pie for you. All right. Any other questions? Well, thank you very much for having me. It was a pleasure to speak.
Okay, on your seats, there should be a little sheet of paper. Some of you filled it out already. If you haven't, we'll give you a couple of minutes, we'll collect them, and this is your door prize drawing slip, okay?
examples of if this happens to your eyes, I wouldn't do this, although other surgeons will, but I don't do this because, but I would do this and the rest of it really has your best interests in heart. He's a very nice man. Very nice, very easy to talk to. Thank you. Right. So nice. I lured him over here, but they did it. So he's with Agnesian. Do you think he's